Greetings, my name is Dr. Warren Smedley, and in this video, we're going to review the class assignment that you've been given to create an executive briefing with PowerPoint. The assignment is to create a 5-minute oral presentation, which you will record and then upload into Canvas about one of the following topics: labor shortages in your hospital, capacity management in the inpatient or outpatient setting, or implementing a new program or technology. You want to frame your presentation as if you're communicating with your boss, and this presentation should include at least 3 to 5 PowerPoint slides. Not too long, not too many, but enough to cover your topic and present it with power. You'll record it and upload it to Canvas. The deliverables: 5-minute recording, needs to be a coherent presentation with at least 3 to 5 illustrative PowerPoint slides, but don't make it 15 or 20. You want to start with a catchy opening or story of some kind. I'll give you an example here shortly, and I'll open with a story. Want to illustrate your substance with a clear fact, data, or illustration. Summarize what you want your boss to take away or what you need your boss to be doing. Practice your presentation. Use the think, write, rehearse technique. Upload your recording and slides into Canvas, and instructions from your instructor. Have fun, enjoy it, let your personality shine through. As you prepare for this presentation, I'm going to give you a few tips here for this one. Remember to stay focused on the topic. Don't ramble. This is to be short and not wander off into all kinds of stray thoughts or directions. You need to be succinct and focused. Now, you have every right to be confident because this is your material, so you're putting it together. If you're making something up, that's fine, but try to use as much of a real example as you can. That way you own it. You've earned the right to talk about it. You know about it, so you have every right to be confident. Practice, yes, but please don't memorize. Memorizing does not work. For very, very few people does memorizing work. You're going to get nervous, you forget where you are, and then you lose your place, and then you have trouble. Keep your notes handy. Feel free to refer to your notes, practice, but don't memorize. Be yourself, dress neatly and professionally when you go before your boss or your executive team or the trustees. That's the time to make sure that you look neat and professional and that you put on your best front for your executives. Now, we recommend you open with a compelling story, and I'll give you an example here in a moment, but choose a brief or compelling story to open with. I suggest you choose a feel-good story that supports the mission and makes the executive team feel proud, or your boss feel proud of being part of the organization. You want to make them feel good about what you're going to ask them to do. You want to emphasize a favorable patient outcome and or highlight the quality and commitment of your team. You want to start your briefing with the story. Start right there. Keep it brief. Don't ramble. Don't waste time. We're talking about 90 seconds. We're not talking about a 15-minute story. This is a 90-second story that makes people feel good. It highlights your team. It supports the mission of the organization. When you put your PowerPoint slides together, spend a little extra time on the slides. Make sure that they look good. I will say your slides should not make sense without you. If you took your slide deck, printed it out, took it to your next door neighbor, asked them to read it, they shouldn't really understand what it's all about. Your presentation should require you to be there making it. Recommend the 6x6 rule as you can. It's not always possible, but try to remember that too much on the slides doesn't work well. It's hard to see, hard to read, especially from a distance. So try to keep your PowerPoint slides simple. The 6x6 rule is 6 lines, 6 words per line. Try to abbreviate where you can. Use high contrast. Don't use pastel colors that fade out and are hard to read. Make your point simple and easy to understand quickly. Use animations to highlight important facts. So if you've got numbers or a spreadsheet or something else you're trying to highlight, just pull those important facts out. Use animations to bold them or to make them enlarged. Just be careful not to cut and paste entire Excel charts into your PowerPoint. I didn't realize this until it was a problem, and that is that when you cut and paste an Excel chart into a PowerPoint, it actually puts all the data of your Excel chart actually into the PowerPoint, and then that data goes with your PowerPoint. So what we frequently are doing in our work is doing PowerPoints and then sending the PowerPoint as a follow-up and reminder to people. You've got to be careful that you're not sharing private data that has gone into your presentation accidentally or inadvertently. Use a PDF handout to support the details. So you don't need to have all the details on a slide crammed in with 1,000 words. You can use a handout as supporting information. If you want to go to a really good YouTube site, try this one. Lila Garani, she does all kinds of free online training on YouTube. She has a great channel and does PowerPoint. She does Excel, Word, all kinds of other things. She's a great teacher, and they're short videos. A lot of good information in there to help you out. So let's do an example of what your assignment could potentially look like. So we'll do this example. This example is based on better lung cancer screening. It's something that I've been working on separately in an organization to help them improve their lung cancer screening program. So here we go with an example. Today, I'd like to share with you how we're looking to improve our lung cancer screening program, especially managing patients with incidental findings on low-dose CT lung cancer screening exams. Last August, we had a 67-year-old male come into one of our locations and underwent a lung cancer low-dose CT screening. The patient was a smoker, but asymptomatic and reported feeling well. Upon the exam revealed a 3-millimeter nodule in the right lower lobes, reported as lung RADS category 2. Also coronary artery calcification, an 8-millimeter thyroid nodule, and unfortunately, a 4.1 centimeter ascending aortic aneurysm. The patient was immediately referred to thoracic surgery. That surgeon repaired the aneurysm, preventing a potentially tragic outcome for this patient. We were so proud of our team for getting that patient identified and routed quickly to thoracic surgery so that they could be addressed. This is not something the patient would have known about. They've reported feeling well and having no symptoms. This is the benefit of doing these, one of the benefits of doing this low-dose CT screening, and this was an incidental finding. We're not screening for aneurysms in the aorta. We're screening for lung problems. We've worked hard on our lung cancer screening program, and lung cancer remains a significant challenge. You're aware of this. You know that there's high mortality in lung cancer, 12% of the total new cases, but 21% of the estimated annual deaths. So it's disproportionate in deaths. Biomarker testing is required for the new therapies, but many patients are not receiving the correct biomarker testing. All the complexities of biomarker testing, getting tissue samples, it takes a long time, and especially in high risk, high need, low resource patient populations, time to treatment delays are becoming significant. They're actually extending, and they've grown from 33 days in 2010 to 39 days in 2018. Disparities in care, as we're all aware, we need to be very conscious of how we improve care to all patient populations coming into our centers. African Americans in one study were found to experience 15 to 20% longer time to treatment initiation, depending on disease stage. It's a problem. Our team has been really good at addressing this. We've actually more than doubled the number of low-dose CT screenings that we're doing, and we're trying to improve then how we manage those patients. Over the last year and a half, we've really focused on how can we increase our low-dose CT screenings for patients that meet the risk qualifications, the appropriate screening guidelines. We've worked with our primary care physicians to do this. We've increased our screenings. Now we're currently running at about 800 to 1,000 low-dose CT screening exams per month. If you multiply that out per year, that's 9,600 to 12,000 screening exams per year. That's way above the national average. What that comes out to look like, if you think it through, we've got 800 exams a month currently, between 800 and 1,000 exams a month. Now, when you do an exam, as we found in the patient example that I just gave you, about out of every 800, about close to 40% of them are going to have some kind of an incidental finding. And we'll talk about that in a moment. About 280 exams will have an incidental finding. And depending on how you define an incidental finding, as much as 95% of the patients will have some kind of an incidental finding, but about 280 of them will have things that need to be addressed or could be addressed if identified. About 32 of these patients will wind up with cancer. That's just under 4% of the patients, either with cancer or with a high probability of cancer. There's a gap between the patients that are screened. Go back to this slide. We see that we've 800 exams. 32 of them have cancer or are highly suspicious for cancer. We sweep them immediately into a work stream that takes care of those patients using patient navigation to walk them through the process. We've got 280 patients a month that do not have a place to go. They have an incidental finding. And at this point, we weren't screening for anything incidental, so we don't have a process in place to manage those patients. We need something for the 35.2% of patients that have an incidental finding on their low-dose CT exam. We need to have some way to help the pulmonologists manage these patients because they're basically coming through their department, and the pulmonologists are resistant to adding volume of patients into their department. We need to use some AI to support the imaging so that we can help to prioritize which of these findings are more important than others. We need to try to reduce those who are lost to follow-up. Many of those 280 patients, we're telling them, you have an incidental finding of X, Y, or Z. You need to come back and see us in 6 or 12 months and follow up. Many of those patients, as many as 71% of those patients, never come back. And yet they have some high-risk issue that needs to be managed. And we need to be focused on reducing time to treatment, especially for those patients who are at risk or have barriers to care. So if we look at those 280 patients and we look at what's the opportunity to enhance patient care for those 280 patients, according to the literature, what we would expect to find out of those 280 patients that have a finding on exam that needs to be addressed, and there's overlap here, so the numbers are going to be higher than what it looks like. There will be, according to the literature, 250 cases referred to thoracic surgery for nodule management, interstitial lung disease, COPD, and things related to lung problems. 56 cases will get referrals, should be referred to vascular surgery for various forms of cerebrovascular disease, abdominal aortic aneurysms, or other kinds of vascular problems. There should be 220 cases referred to cardiology. This is apparently very, very common. We get coronary artery disease that shows up in these screening exams, pulmonary artery disease that shows up. They need to be referred to cardiology and have that followed, like our patient that we found. Referrals to general surgery for thyroid nodules, very common to find a thyroid nodule on exam. And these are the common ones that are pointed out in the literature. There may be other things that we find. That's 541 cases that we have not been referring within our organization. We've missed those. We've sent the patient home and told them to follow it and come back and see us in 6 months or 12 months. We have potentially 541 cases of patients with a high-risk situation that needs to be followed carefully that we're sending home and leaving them on their own. That's a huge opportunity for us to enhance patient care. So what I would ask from you is to allow us to create a new role to help us manage those cases. And that role would be a pulmonary nurse coordinator. Think of them as a navigator for pulmonary. This individual will help to identify which patients with these incidental findings are the higher risk ones and triage them, refer them to the right locations, make sure that they get a multidisciplinary case review on their particular case. They'll follow the patient, try to identify clinical barriers to follow up, and then assess them for additional needs that we can make the proper referrals for. At the current caseload, this is just the current caseload, and we are working hard to increase the caseload. We'd like to double that caseload and get to 2,000 screening exams per month. We're getting 541 new referrals, potentially new cases that this individual could coordinate for us. That generates a tremendous amount of revenue for our organization, as well as enhances patient care. And that's the example that probably took me 10 minutes, but that would be an example of how you would put together this particular assignment for your professor. Best wishes as you embark on that, and we'll see you at the upcoming class.